Hello, everyone. Welcome to DocTalks. I'm Dr. Manju George, the Scientific Director at Paltown Development Foundation, the nonprofit that supports Colon Town. And today we have Dr. Ben Schlechter and Dr. Josh Smith to talk to us about surveillance and after treatment for non-metastatic rectal cancer. Dr. Schlechter, do you want to start first?
Sure. So I'm Ben Schlechter. I'm a GI oncologist here at Dana Farber in Boston. My main clinical interest is rectal cancer, and my main research interest is actually in immune therapy for these diseases. And I know that's been a hot topic. Always happy to talk more about things like botensilimab, emerging therapies, and things like that. But rectal cancer, obviously, we know is a very important topic. All right, so I'm going to talk a little bit about how we got to the modern treatment of rectal cancer and what the modern treatments are, because there's this laundry list of things. And that I think is going to lead us into how do we monitor patients after they've had all these cool developed treatments. These are my disclosures. So there's a few major paradigms for the treatment of rectal cancer. Obviously, there's the conventional treatment, which now would be considered old news, and that was a 40-year effort to get there. There's the modern total neoadjuvant therapy, everything before surgery. There's these intensification, de-intensification projects. So can we use more or less chemotherapy to make quality of life better while maintaining safety and cure? And then there's the where to from here, and Dr. Smith has a lot to say on this topic with new trials that are open and enrolling in the US with Janus and the ACO trial in Europe. So this conventional approach is a 40-year effort. And really going back to the 80s, we had finally in the late 70s, early 80s, surgeries that worked in rectal cancer. There was an observation that radiation was helpful. Radiation became a preoperative treatment. Chemotherapy was added. And then finally, by 2014, we could publish mature data with a paradigm that was already out of date of chemoradiotherapy before surgery, then adjuvant chemotherapy to prevent recurrence with FOLFOX. And that really sets a standard for rectal cancer entering really the last 10 years for us. Throughout this era, there was lots of observations that there's more than one way to do this. And one of the important things is something called short course radiation, which is used widely in Northern Europe and to a lesser degree in the US, but in many centers, it's becoming popular. And short course also moved to the total neoadjuvant therapy era where everything was done first. 5 days of this more intensive radiation, followed by chemotherapy, and then followed by surgery. And that was compared to that good old fashioned chemoradiotherapy, take a break, surgery, take a break, FOLFOX. This is the Rapido trial. Its name tells you what it does. It moves things a lot faster. Everyone who was treated with either that standard good old fashioned Adore style treatment and with the Rapido approach had about the same overall survival. There's lots of little nuances here, which is there were some people who had more local recurrences with the Rapido approach compared to the conventional approach, but it didn't jeopardize cure. And so this is an important treatment when you think about the convenience of therapy and what do we do here. And the German Rectal Cancer Study Group that we mentioned earlier is looking at this to try to understand non-operative management here. The non-operative management story in the US looked at that conventional long course chemoradiotherapy, but moved it to a sequencing question. And this was work really led initially from observations in Brazil by Dr. Halbert Gama that we could maybe avoid surgery, and then really excellent work at Sloan Kettering to try and define what's the best way to get someone non-operative management. The goal wasn't necessarily set out to do this, but it's what it really achieved. And what we could see is that you could do sequencing of therapy without jeopardizing cure, and that a substantial number of people could get cancer free, and about 44% after all this treatment. When I say FOLFOX here, I mean FOLFOX and CAPOX for convenience and space purposes. And that many of those people, maybe half of them, could go on to never require surgery. And that's really important when you're thinking about folks with low cancers who are at risk of a permanent ostomy. Equally important is the intensification and de-intensification story. So in Oprah, that was looking at how can we avoid surgery entirely. Whereas the Purdue study, which came out of France, this was let's give the most we got and let's see if we can get things better. And this is a hard study, but it's an important study. The reason it's hard to interpret was this was using FOLFIRINOX, which is good old-fashioned FOLFOX, plus the addition of irinotecan. That's the regimen FOLFIRINOX. Patients received that 3 months before surgery, then chemoradiation, then surgery, and then additional 3 months of FOLFOX, compared to that good old-fashioned Adore paradigm of chemoradiotherapy, surgery, and then additional chemo. One of the challenges here is that patients didn't really complete the postoperative chemo. And in fact, a third of patients didn't really get any chemo after surgery. And you end up with a trial where one group got FOLFIRINOX for 3 months before surgery, comparing to a group who didn't get any chemo. at least a third of them, and that makes it hard to interpret. So while this trial definitely showed that in this data set, in this approach, FOLFIRINOX is better, it may be that if you complete all your treatments, they may not be better. And that's a question that's being answered in a lot of ways. And one of the ways it's indirectly being answered is with that Janus trial, which is chemoradiotherapy followed by chemotherapy. And the randomization is to FOLFOX versus this boosted regimen, FOLFIRINOX, to understand non-operative management and boosted chemo. The flip side of that is Prospect, which I seem to have lost my slide. So Prospect, we'll just talk about in this context. Prospect was a recognition that for the lowest risk cancers, maybe radiation's too much. And if you give people chemo, maybe if they do well, you don't need its radiation at all. And in fact, that turns out to be the case. So for patients in whom a permanent ostomy is not a risk and where their cancer is sort of the best possible risk for the surgeon to get the patient cancer free, maybe good modern FOLFOX is so good that we could skip chemo. And in fact, we could 91% of the time. The responses were so good that patients could avoid chemo radiation entirely, and that improves fertility or preserves fertility. That improves bowel function. That improves sexual function. Those are really important quality of life metrics. And then finally, Janus. So I think for everyone in the US, if you have the option, you should join this trial. It's rapidly enrolling. We'll hear from Dr. Smith about when it's going to complete, hopefully. But this is a great study. This takes those modern paradigms of radiation first as a great pathway to avoid surgery for patients where that's relevant, right? If you're one of the patients who could avoid radiation entirely, maybe that's a consideration. And looks at FOLFIRINOX versus FOLFOX and is going to help answer the question of the role of FOLFIRINOX and help us better understand non-operative management. The other thing that I was tasked with talking about liquid biopsies and ctDNA. And this is a hard topic because we don't have agreed upon language. So there's lots of different tests, lots of different advantages, using it lots of different ways. In the advanced disease setting, there's different commercial studies like Garden 360 and Foundation One and others. And that's about identifying driver mutations that maybe we have a drug for. And that's important. And in the early stage setting, that's about trying to figure out, can we predict the risk of recurrence and can we do anything about that risk? And that's a hard question to answer. So generally speaking, when we're talking about it in the context of early stage disease, stage 2 and stage 3, and maybe resected stage 4A disease, we're talking about assessing risk. And it's important to note that rectal cancer and colon cancer should not be considered the same disease, really ever, but in particular in this situation. And I think that the better way to look at this at this time from the data we've got is, can we use these tools to avoid chemo in some patients? And it's not really clear if we can use these tools to add chemo that we don't know about just yet. So I think we're not quite there, but we can talk a lot more about that. And there's some other sort of cool, interesting numbers to know about here. So first of all, a positive ctDNA after surgery is uncommon. 5% of stage 2 and 20% of stage 3, give or take a few percent. That has been shown in multiple clinical trials. It's very clear that a positive result means that your risk is higher, but that's no guarantee of recurrence. And it's very clear that a negative result means your risk of recurrent cancer is lower, but that's no guarantee that you're protected from recurrence. And when you look at these trials time and again, the number of people who get recurrent cancer is the same. And sort of an interesting thing about the lens that you look at, if you're sitting in the room and if you're a patient with recurrent cancer, it's a 50-50. Your ctDNA was positive a month or two after surgery. But if you look at the people after surgery where it's negative, chances are they're not going to be those 50-50. And so you have to be really careful the lens in which you examine these numbers and how you think about them. But just be aware that of the folks with cancer long after surgery, half of them will have been ctDNA negative. So we have to be really careful how we use these numbers. And this is an example of that. This is from the Bespoke study presented by Paltown Scientific at ASCO last year, GI ASCO. And you can see that top bar looks great, but it's not 100%. And you can see that bottom bar doesn't look great, but it's not 100%. And so these are important studies, but they're not the only study we got. The other thing to know about ctDNA is it has certain blind spots. It's less good at lung mets than it is at liver mets, actually quite good at liver mets. It's less good in what are called T4 tumors that are penetrating into surrounding tissue, which is particularly relevant with rectal cancer, where T3 and T4 are conflated concepts biologically. And once again, T4 cancers are more likely to have lung metastases and peritoneal metastases. And so this is a really meaningful test, an important test. I think this is an important thing for us to be doing and studying, but we have to let ourselves be carefully reassured or worried at the right moments. And the other thing is, when we look at rectal cancer and colon cancer, actually the results give us different things. This is from Gene T study out of Australia. This is a dynamic study looking at rectal cancer, not colon cancer. And you can see the absolute number of people who get cancer at the end's about the same from the CT negative and ctDNA positive, but how they get cancer is different. So ctDNA negative, these are the numbers. It's usually going to be lung mets, and lung mets have a totally different biology and outcome than liver mets. And the ctDNA positive is that more conventional liver metastasis. So this is confusing stuff, right? But here's my take home. I would say no test that we ever do for cancer should ever be the only test. We should always think of this as one of many factors. The other thing to think about whenever you're talking about treatment for cancers, curative intent therapy, postoperative therapy, adjuvant therapy, even neoadjuvant therapy, that's about reducing risk. So if the risk is low, chemo doesn't add much, chemo adds risk. If the risk is high, then chemo adds a lot. And rectal cancer is a great example of a cancer that's often high risk. And so chemo and radiation, things that often add something to rectal cancer because the cancer is a problem. ctDNA is an excellent test for risk, but there's lots of other ways of assessing risk. And that's the important lesson. So I think we should think about ctDNA as a powerful tool. We should incorporate it into clinical trials, and we're trying to do that. And we should remember that it's not an absolute, but it's really, really important. And it leads to a lot of stress and confusion, but I also think it leads to a lot of helpful info and gives us a warning about what may happen. So sort of my final thoughts, rapidly moving through a hard topic. The modern treatment of rectal cancer has been many decades of work focusing on increasing cure and quality of life, and that's important. For patients interested in non-operative management, a radiation-first approach is best, and I would encourage folks to enroll in the Janus trial, but there is the Oprah approach. For patients where non-operative management isn't really an important factor for upper rectal cancers or just something they're not interested in, I think that the prospect approach of chemo first and see if you can avoid radiation is important to improve quality of life without jeopardizing the chance of cure. For the situations where intensification makes sense, very symptomatic cancers, very high-risk cancers, FOLFIRINOX is appropriate, and it's a very important regimen. Short-course radiation is fast, just as effective as good old-fashioned treatment. These all have about the same cure rates, and so I think it's out there and was vital during COVID to get patients quickly through therapy without exposures. And ctDNA and liquid biopsies are an important new test. We're getting better at using them. We're getting better tests, but I think we have a lot to learn still. So hopefully we'll have a lot more to talk about. Hopefully that was fast, but concise, which is not my natural state.
Okay, thank you very much, Dr. Schlechter. Dr. Smith?
Great job, Ben. Great topics and very insightful. I'm Josh Smith. I'm one of the colorectal surgical oncologists here at Memorial Sloan Kettering, and I'm going to talk about one of my favorite topics, other than non-operative management, but surveillance in non-metastatic rectal cancer. And I've adapted this just because it hits a couple of my pet peeves. And actually, I see why Ben and I get along so well, because he hit on one of mine. So, Manju, thank you so much for having us. And I'll just cover my disclosures. I just want to say from the colorectal surgery group at MSK, greetings to everybody. We're so happy to take care of patients with rectal cancer. And one of the things that really I think is important is where you start in rectal cancer and then where you finish. And part of that is I think intimately connected is the appropriate pre-op staging is, I think, very well connected to how we survey patients. So my overview is the context of that pre-op staging for rectal cancer, and then post-op surveillance, a little bit of data in that regard, and then how we do surveillance and watch and wait. So these are my general principles, and I teach these to anybody who will listen. And then Ben and I have one thing in common in our slides, that rectal cancer is not colon cancer. And I think this is something that I try to drive home to the fellows and medical students and residents. But when we are faced with a rectal cancer patient, I try to make it very simple for the patient and the people who are taking care of the patient, but you have to name it, stage it, treat it. But then I think really important now in the rectal cancer space is we have to survey the response and then also what that outcome is going to be and how we determine and assess that outcome. So what's the standard for staging in rectal cancer? These things sound obvious, but it really, almost every week I have to redo or undo or establish how these things are done in clinic. And the basic things that we need for rectal cancer are an exam. You need endoscopy, you need a biopsy, you need pathology, which is going to tell you whether this is a mismatch repair proficient or deficient tumor. You need a complete colonoscopy if it's possible, or an early interval endoscopy after all the treatment is done, and of course, lab work. And then what we often do are a series of imaging results and tests. And these are important because they also become integrated in the surveillance. Typically, it's a CT, chest, abdomen, pelvis. We typically do not do a PET CT, and we oftentimes have to talk people off the edge about getting a whole body scan, but these can give you all sorts of things to chase down that are irrelevant. But really what's important is an MRI of the rectum. Very rarely these days are we using a rectal ultrasound. That can be helpful in early stage rectal cancer, but very rarely. You can use MRI abdomen and pelvis or an MRI liver, but I'll go into why we do those in a second. If you have contrast allergies, then of course we can do special studies like an MRI abdomen or pelvis without contrast. But this is for people who have renal dysfunction or severe allergies. So there are certain tests that we can do that we coordinate with radiology to do that. And then if there's a concern for a liver lesion, we typically do a triple phase CT abdomen or an MRI of the liver. This is very common if there's any concern about metastatic disease in the liver. And then if there's suspected liver disease, we often talk about these patients in our disease management team meetings. We definitely confirm the mismatch repair status and then also discuss whether or not it's important to do additional genomic profiling of the tumor. And then in some cases, you may use a PET CT, but that's typically after treatment has been given if you're worried about multifocal disease. And then you can consider surgical resection in the cases of obstruction, bleeding, or if there's high risk for perforation or significant symptoms. So what's the standard monitoring schedule when we give treatment? And so, of course, at presentation, we do endoscopy and MRI, and it's important because we want to know the distance from the anal verge, the tumor length, the tumor stage, how this tumor is related to the mesorectal fascia, the nodal stage, and another really important thing now is a thing called extramural vascular invasion. There's no real clear consensus on reporting of this yet, but we know that this is associated with higher risk disease, and so we need to know that on the baseline MRI. And then after neoadjuvant therapy, we look at all of these same things, but we want to make sure that we have comparison with the baseline endoscopy and MRI so that we can determine what the change is or what the delta is from the baseline. So can we see, are the mesorectal fascia planes clear if we're going to surgery? Are the sphincters that were involved, are they still involved? And because all of these things are important for our surgical planning. So what about stage-specific surveillance? So for early stage tumors, we can do, like I mentioned, in rectal ultrasound, but typically most rectal cancers nowadays are managed by MRI. And for early stage cancers, we do this for the first 2 years and then every 6 months for the next 5 years. Really, I think that's changing now really to up to 3 years. And then if clinically indicated in years 4 and 5, and I'll tell you why that is in a second. And then colonoscopy we do at 1 year after diagnosis. And if there's an advanced adenoma, then you may repeat that with your gastroenterology colleagues. And if not, then we move to every 3 years. And you'll see that this theme persists in terms of how we look at stage 1 tumors. And then also, even as we go forward to stage 2 to 4, you can see, though, that the history and physical exams are increased in frequency when we have more advanced tumors. And then we also started measuring CEA. And you can see chest, abdomen, pelvis at more frequent intervals for stage 4 disease. And then you can see every 6 to 12 months as clinically indicated for patients with stage 2 and 3 disease. And colonoscopy is very similar. But again, PET CT is not something that we just standardly recommend. So what about stage-specific imaging surveillance? So for stage 1, it's very important to note that we don't recommend routine imaging for these patients. It's just exams, and then some people check CEA and then check them based on symptoms, because these people are it's an extremely high rate of cure for these patients who have stage 1 or carcinoma in situ rectal cancer. Stage 2 and 3, we do CT chest and pelvis every 6 to 12 months, and then for 5 years. And I'll just reiterate again that CT we don't typically recommend. And stage 4, we do image these people more often for a couple of years, every 3 to 6 months, and then as they get further out with disease stability, we may extend that. So what does the recent literature add to the guidelines that are in the NCCN and what we've adapted clinically, both here at MSK and other high volume centers? I'll just let you know that there is limited modern evidence on frequency of surveillance, but there are some good studies. And I think there are recent trial data that even inform what we do and has also informed how the NCCN has recommended some surveillance studies. Because there's certainly limited consideration of underlying recurrence risk in terms of the biology that's there. And there's certainly lack of standardized approaches in many routine clinical practices. And I would suggest that you have be managed by somebody who has a very standardized approach, because I think that's important. So Ben talked a bit about OPRA, and I think this is really critical to know, because in the randomization, we did see that there were lower rates of local regrowth in those patients who got chemoradiation followed by chemotherapy versus those who had induction chemo followed by chemoradiation. And what you can see here where that arrow is the 1-year time point. And you can see that very high number of the local regrowths occurred in that 1-year time point. And by the end of 2 years, you can see that it almost plateaus out. And then in the 5-year data, you can see that persisted, that there were lower rates of local regrowth in that consolidation group versus the induction group, and that the disease-free survival rates were similar. Sphincter preservation rates were similar if you went to surgery up front versus later. And this is important because we know that if we go down this route of a non-operative management approach, all comers, it's about a 36% rate of regrowth, and 94% of these occur in the first 2 years, 99% in the first 3 years. And as I mentioned, a lower rate in the consolidation group versus the induction group, with very similar rates of disease-free survival, and that you could have the same operation at restaging versus at regrowth with very similar disease-free survival. The reason I bring this up is because previously the NCCN guidelines and other guidelines had recommended MRI for up to 5 years, just routinely. But you can see that after 3 years, the chance of detecting or even developing what we call a local regrowth is extremely low. And so now what's been done is up to 3 years, we go every 6 months, but then you can then move to as clinically indicated in years 4 and 5, which is, I think, a very interesting change, and based on, I think, what is very good data, both on and off protocol. So there's a study that was run by a woman named Rebecca Snyder, who's now at MD Anderson, that I think is also informative in terms of surveillance, whether we do what's called high intensity surveillance or low intensity surveillance. And I picked this study. It was published in JAMA. It reflects about 8,000 patients after exclusions, but both colon and rectal cancer patients. And they basically just said, we're going to randomly sample patients from multiple different sources, from the Alliance, from the Commission on Cancer, stage 1, 2, and 3 patients, both who had colon and rectal cancer, and see those who had low intensity or high intensity imaging, CEA surveillance, and then also see if there was any differences in outcome. And what you can see here in terms of recurrence and the disease-free survival, you can see really no differences. It's really hard to see if you can even get a tip of a pencil between these lines. And then overall survival, you can't even imagine getting a tip of a pencil between any of those lines, high intensity versus low intensity surveillance. And when you look at the data of these 8,000 patients across almost 1,200 facilities, you can see the median time to recurrence here is not very different. So in the high intensity group, 15.1 versus 16 months for low intensity. And then for if you did imaging versus CEA, and then 15.9 versus 15.3 months. So you can see that that's it's very difficult to determine whether if you got a CT at 3 months versus 6 months, or a CEA at 3 months versus 6 months, are you going to make any difference in the outcome? And the NCCN does speak to this in some ways and says that the panel endorses surveillance, but they're not really forcing your hand on how you're going to I guess, enforce your surveillance, other than just trying to stick with a surveillance plan that makes sense. And I think as long as you stick with something that has some structure and that I think follows what's been advised, I think it makes some sense. So what do we do at MSK? Well, we have a model where we integrate both practitioners and physicians in a multidisciplinary fashion. We have some variation toward the end in terms of active surveillance, where we share visits with our practitioners, and we also do some of that in the beginning. And then the important part of survivorship is trying to see when can we then let patients go back to their primary care physicians, which is typically around 5 years, and make sure that we're screening for new cancers, making sure that they have all their regular health checks done and don't lose them to follow-up. So who can go back to their primary care doctor? I think rectal cancers that have been undergone surgical resection and have no disease after 5 years. We don't typically do that with patients who are under watch and wait or have serious effects of treatment. The young onset patients, stage 4 or hereditary syndromes, typically don't go back to the primary care doctors. So stage 0 or rectal cancer patients, we use this same model where we can start off with a multidisciplinary approach, but then pretty quickly move them to the physician extender model. Versus more advanced tumors, we do a shared model, of course, with medical oncology, radiation oncology, and then eventually, once they've either been cured or their disease is stable, then we move to our survivorship model. So I'll end with just talking about what do we do about watch and wait and surveillance. So what's the role for ctDNA? Should we be doing more frequent endoscopy? Should we be doing more frequent imaging or CT scans? And I'll just address with what we're doing currently in the Janus trial, and maybe that'll inform the discussion and maybe some questions. But as of Monday, we have 391 patients accrued to this trial, and Dr. Schlechter talked about this, so I'm not going to further go through the methodology here, but this is more than 50% accrued. It's well ahead of accrual, and I think it's just because patients want to keep their rectums, and this trial is similar to Oprah in saying that it gives you a chance to do that should you achieve a clinical complete response. And so how are we surveying patients? So these are the surveillance schedule is based on data. It's based on the Oprah data and also off protocol data. You can see for the first 2 years, it's more frequent. Digital exam and endoscopy every 3 months, MRI every 6 months. CT scans are once a year throughout the trial. And then colonoscopy, you can see, is based on what I just told you in terms of the NCCN guidelines, depending on what we find at that first colonoscopy. And then years 3, 4, and 5, you can see we start to move toward every 6-month digital exam and flexible endoscopy. And then the MRI starts to space out based on what we saw in Oprah to every 12 months versus every 6 months. And then years 4 and 5 are just as clinically indicated, which I think is important and based on data that's essentially hot off the presses earlier this year from Oprah. So, and then in terms of what are we doing for ctDNA? Well, this is a hot topic because a lot of people say, well, why don't you just use ctDNA to make your choice about whether or not you keep the rectum or not? And I don't think we're anywhere close to that, making that decision or integrating that decision into the trial. So what we're doing is we are collecting plasma for both patients who are undergoing watch and wait and surgery, and that's done right before treatment, between the period between radiation and the initiation of chemotherapy, and then at the time of restaging after they complete TNT. And then, of course, at the time of surgery, we can also get an additional draw, and then throughout surveillance. So right now we're slated to get 7 draws on the patients, but we have not yet decided on a platform. And I think the reason for that, I think, is really clear when you hear what Dr. Schlechter just talked about in terms of detection. We're not really sure is whole exome the best way to detect circulating tumor DNA in these patients because of the issue with lung metastasis, and also can we detect local regrowth at a reliable detection rate, because really that's the problem that we still face in rectal cancer, as I mentioned. So to keep it simple, name it, stage it, treat it, then survey smartly. I think it's really important to think about the NCCN guidelines. They get updated about twice a year. And as I mentioned, more surveillance is not always better, but I think smart surveillance is. I'll end there, and I'm happy to take questions in conjunction with Dr. Schlechter, and hopefully we'll have some time for good discussion.
Okay. Okay, thank you, Dr. Smith. That was very helpful. So I think before we start with the questions, I wanted you to, if you can tell us a little bit about CRM and MRF involvement. I think this is a question that we see in the group. People are really confused about what they see on their reports and how they have to think about it. So it'd be great if you can spend like a few minutes.
Say again, you broke up when you said the question. I didn't hear what you said.
Oh, about the circumferential resection margin and the MRF involvement, both of them.
Yeah.
A little bit
So, yeah.
in simple terms for people to understand what it is, because we often get questions and it's a little bit technical, right?
Yeah. So circumferential resection margin, essentially that's going to be the radial margin. If you think about the rectum as it's facing the tailbone, that's an area that sometimes can be at risk. And so you worry, can you get that area off cleanly? Because when you do a mesorectal excision, you want that mesorectal fascia to be intact. That's really important. So one of the key quality indicators of a good rectal operation is the mesorectum intact. So that envelope should come out cleanly. So if you think about a Coke can, for example, that you just bought from the store, you'd want it to be pristine, not have any scratches on it, right? And so in that way, the mesorectum needs to be nice and clean and intact. The mesorectal fascia is just another way to say that's the fascia that's around that circumferential resection margin. And so sometimes that's invaded by tumor. And so that's where our radiation colleagues are really important, because they target those areas that are potentially at risk. And so these all can be areas where the margin can be close. And so we want to make sure that that margin is, an R0 resection, meaning there's no tumor anywhere near that margin, and less than, you saw in this slide I put up, you want to be much less than 1 millimeter. If it's more than 1 millimeter or close to 1 millimeter, it can be considered an R1 resection, which is not, the end of the day, but it's still not ideal. And R2 means there's gross tumor left behind, which is unfortunate. A positive radial margin, then you have a discussion. So that would lead, if Ben and I were managing a patient together, then we would have to discuss, are we, do we need to do any additional treatment, or how are we going to monitor that? And this is something that's very difficult, because one thing that we think about in terms of margin status, if you knew that the tumor was invading, for example, into the sacrum, then you wouldn't do just a standard total mesorectal excision. You would start thinking about a beyond, what we think about as beyond TME resection, right? Because if tumor is invading into the presacral space or into the sacrum, then I need to start thinking about a resection that removes a part of the sacrum, so that the backside of where that mesorectal fascia is negative, right? So then that way I don't have to have a challenging conversation with Ben in the postoperative setting, or with the patient, that, our margin is grossly positive. I think in the current day and age, with the imaging that we have, it's typically an avoidable scenario. It can happen, but it certainly can be avoided with really careful preoperative planning.
Yeah,
okay.
and that also
okay.
speaks.
Thank you.
That speaks, I think, to the choice of the neoadjuvant therapy that we offer. If you really think a margin is threatened, you have to make a number of assessments. And one of them has to do with radiation and timing. So radiation is really, really powerful in clearing a margin, but radiation needs a lot of time. And so for paradigms where someone does chemo first and then radiation, and then surgery happens quickly, that may be positive under a microscope, but that does not mean that those are viable cells. And so there's a lot of context in what those margins mean and the sequencing of therapy. And we know from other cancers like anal cancer, which is a similar cancer, but not the same, that if you biopsy a cancer 3 months after radiation and then don't do surgery, and you go back 6 months after radiation, from the start of radiation, and look again, that cancer can be gone. And so a positive margin happens, and it's really stressful. But but it needs a lot of context. And the effort is always on my side as the chemotherapist. My job is to make his job, Dr. Smith's job, easier. And the radiation oncologist's job is to make Dr. Smith's job easier for the sake of the patient. And so as much as possible, we need to like line up our various modalities to try and avoid that situation. But if we avoid that situation, we have to always put it in context.
Okay.
Yeah.
Thank you very much. So I think this is a very, the fact that all of these are different ways to describe the extent and location of the tumor, but having the involvement doesn't mean that it's the end of the world, right? These are different ways of assessing it. So maybe that's a very important and great message for patients, because I also see this, that like somebody gets a TNT and then they don't have a PAT-CR, and then patients are really concerned that that's really not good for them. But if you look at the, even in OPRA, there is a certain amount of PAT-CR rates, right? It's not like every patient will get PAT-CR, and then that also doesn't correspond to an increased chance of recurrence, right?
Mm-hmm.
So it's not like completely corresponding.
No,
right?
and Prospect informs us a lot. So Prospect, again, that was the study arm got 3 months of FOLFOX. If it worked, they went right to surgery and then postoperatively, give or take, 3 months of FOLFOX. If it didn't work, then they got radiation and so forth. And the control arm was good old-fashioned chemoradiation. And everyone was the same. So the people who had an under response but got all the bits, people got the old-fashioned chemoradiation surgery, people had a good response and got chemo. On balance, it all worked out. And so, yeah, of course, everyone wants to have their cancer die. But at the end of the day, the most important question is, are you cured of cancer and how's your quality of life? And it turns out that it's okay to get a passing grade. We don't all have to be overachievers at every step along the way. And outcomes are pretty darn good.
Okay,
That's how I
great.
think of it, as I'm overdue for my grades with the Harvard medical students, all of whom are above average.
Yeah. And Manju, I think it's really important to think, to start. And the reason I started with stage the cancer appropriately, because that's where you manage expectations, right? Because not everybody's going to have a clinical complete response, and not everybody's going to have a pathologic complete response. And if you look back across the evolution, like Ben showed a really nice diagram from the last 40 years of rectal cancer treatment, that we've moved the needle some in terms of overall survival, disease-free survival in certain situations. But at the end of the day, the 3 to 5 year disease-free survival still sits in that range of about 75%. Sometimes it's up a little bit. So Prospect, the numbers are a little bit higher. I think as we move into the more modern rectal cancer paradigms, maybe we can push those numbers a little bit higher. And so, our goal with Janice, for example, is can we improve survival? And I think in the Produce 23 study, he talked about there was a goal to improve survival, which is why I think that trial gets some additional attention, because we want to improve survival and yes, move that average number of 3-year disease-free survival of 75% up. Can we get that up to 80% or 85%? But just because you don't have a complete response doesn't mean you should give up hope, because still 75% is still pretty good, right?
Mm-hmm, mm-hmm.
And then, of course, we have hope for new treatments as well.
Correct.
For,
yeah,
for
there's a lot of things coming around the corner that will be helpful in many different situations.
Okay. The other question I had was that in your OPRA trial, with the different, either induction or chemoradiation or consolidation chemo, you were talking about there was a difference in local regrowth, but the DFS rate were similar. So basically then patients don't have to worry that, they got this sequence versus that sequence. It's only in terms of if you have radiation first, the chances of them getting to a non-operative management is higher, right? But overall, the outcomes for the patient, even if there's a local recurrence, they are salvageable, and so the disease-free survival rates don't vary much. Could you both expand a little bit?
Yeah, disease-free survival was quite similar in both groups, not significantly different. There is a pretty significant difference in local regrowth, however, so that means that more patients preserve the rectum in the group that got radiation first, followed by chemotherapy. So
Yeah,
higher rates of organ preservation, which is important to think about. So if you're thinking about a patient who wants to preserve the organ, and if you're putting your bet on getting a clinical complete response, you would want to start. The best data we have right now would suggest you would start with long course chemoradiation, followed by chemotherapy.
Yeah, and I think it's important to remember that all the components of rectal cancer treatments pretty much with some nuance achieve the same survival endpoint. And so what we're doing is shifting around the sequence of events to maximize the quality of life impact. And that is really, really important that you correctly stage the patient, make an assessment of risk. You got to weigh in on honestly on what do you think you can achieve, and then use the tools we've got to achieve the best possible outcome for the patient, knowing that frankly sequencing matters for a lot of different outcomes, but good surgeons can make up for, I don't want to say good surgeons can make up for bad radiation, but good surgeons can make up for a suboptimal sequence if you don't get what you want, and that's okay.
Okay. So there are some questions. So Liana asks, in the event you have a positive radial involvement post-op, example with an APR, I think that's what she means, and have had TNT, is surveillance preferred over adjuvant chemo?
I think if you've already had the full course of chemotherapy, more chemo is not necessarily better. And it's important to remember that chemotherapy does what's called a log kill. So let's say we just make up numbers and it kills a half with the first cycle and then a quarter with the second. Another half gets you an eighth and 16th and a 32nd and a 64th and a 120th. You end up with it with sort of just levels off in benefit. So I don't know that more chemo is more better, but I do think that's a hard situation, and surveillance is hard there because we don't actually know what the best surveillance is. And we had the conversation of ctDNA earlier. We don't actually know if ctDNA is a really valid test for that type of regrowth. ctDNA is probably best for detecting things like liver metastases and may miss that. So I think that's a situation where, unfortunately, it's a hard conversation and good judgment, and a lot of worry and careful watching is what we have to do. But I don't know that more chemo is more better if you've already had what you need.
Okay. Thank you very much.
I agree.
Yeah. Okay. And Dr. Smith, when you were talking about MRI and the frequency of MRI as we go, with past many years in surveillance, you're talking about a pelvic MRI, or you're talking about a rectal MRI?
It's a great question. So you can have an MRI of the pelvis, but it needs to be on a rectal protocol, right?
Okay.
Because you don't want to do an MRI of the pelvis that cuts off at the top of the sphincters, right? You need a rectal protocol that goes all the way down to the anal skin and below. So you need to make sure that you have the entire pelvis, including the sphincter complex and the anus in the view. So there is a classic rectal protocol that's done that is key for the appropriate and proper staging of a rectal cancer. So many times it's not done. You just get a regular MRI pelvis, and that needs to be redone so that the rectal cancer is appropriately staged. That's important for multiple different reasons. One is because you need a really good pre-treatment staging exam. It's also helpful to the radiation oncologists who use images to stimulate the tumor to provide the best chance to kill the tumor and also the lymph nodes. And so they want to target it in the best way they can. So a really high quality pre-treatment MRI is absolutely critical.
Okay.
And one thing that comes, sorry.
Yeah, go ahead. Sorry.
Just an imaging thing, sometimes what happens is patients get the CAT scan before the MRI and there's something questionable in the liver. And an MRI that can best assess the liver actually can't really be done at the same time as an MRI that best assess the rectum.
Right.
And so rectal protocol MRI cannot be done at the same time as a liver protocol MRI because of the timing of the sequences.
It's two separate days.
It's two separate scans, and it's really frustrating because it's a stressful, really miserable situation when you have to do the scan do it again. But that is because the best way to see the rectum, the best way to see the liver just can't be done at the exact same moment.
Okay.
Yep.
Okay.
Thank you very much. Point.
Yeah. And there was also a recent discussion about, when patients are told that they're getting an MRI, there were many people who commented that they got like contrast into the rectum, whereas in some places they don't do that. So is there like an advantage to doing a contrast in the rectum versus MRI with the regular IV contrast? Or is it just what is practiced in different places?
It's a different practice at different places. It's tried, there's been an attempt by the radiology groups to make it standardized. Some places have moved to doing what's just a mini enema to clear any stool out of the rectum, which is very helpful. Because a rectum full of contrast distorts it some and makes it difficult to see very carefully. So there's certainly a standard protocol that's done, but there's been a move away from filling the rectum full of contrast because it can distort the rectum unnecessarily.
Okay. Yeah, it was news to me because I have not had one of those. So it was surprising that there is so much difference in how it's being done in different places.
Yeah, and there's also other
there's a wide variability.
Injections. There's lots of stuff.
Yeah. Right. Which makes people feel a little woozy. Yeah. Especially if they've not eaten in preparation for the flex sig on the same day.
Okay, so what you're saying is that there is variation in how these procedures are done in different places.
Yeah, I think it goes back to the point that was made is if you're thinking about doing something like non-operative management, it's important if there's a protocol available to do it on protocol because those things are all protocolized. So you're not just getting things here and there in a very heterogeneous fashion. We try to do it in a similar fashion on a protocol that's been vetted and been very well, carefully selected by radiologists, and the group of radiologists have agreed across multiple different groups. But that's also that's why I refer people to the NCCN guidelines because that's also there.
Okay. Sounds good. Okay. How far out post-surgery does ctDNA provide useful information on recurrence? Example, years 4 and 5. Is there, is there value to doing it?
I almost want to try not to answer that question. So I would say, ctDNA that far out is important about assessing risk. And I would say if ctDNA becomes positive that far out, you have to start looking really hard for where it's coming from. The test that you use is really, really important. So if 5 years from rectal cancer surgery, you're using a tumor agnostic test, so not one that looks for the mutation specific to that tumor, but a general test, that may be detecting any number of things, something called CHIP, which is sort of like random mutations in your bone marrow that contaminate your blood with meaningless mutations that may or may not become a problem. You may be identifying a woman who's got a second primary breast cancer unrelated to their colon cancer. So ctDNA testing matters. And if it's tumor informed versus tumor agnostic, matters. So there's a lot of, I think it's a hard question to answer because it depends what test is being used and how. But I would say a tumor informed test that becomes positive 4.5, 5 years out. The reason we do all these testing, the reason we do CAT scans for 5 years in CEA, it may not change the outcome as Dr. Smith pointed out, but we're doing that to look for cancer. And so if you're doing this to look for cancer, that should trigger you to go look for cancer and look really, really carefully. That's how I would interpret it if it's tumor informed. If it's tumor uninformed, you have to do that plus a mammogram or a pelvic exam or a prostate exam. You have to look at the blood. That's a much harder test to interpret.
Okay. So what you're saying is that if it's a tumor-informed ctDNA MRD test, then that gives you more specific information about the recurrence of the colon of the rectal cancer. Mm-hmm. Whereas if it's like almost like a liquid biopsy, which is looking at tumor markers, then you don't know if it's coming from the same primary.
And some of them have only a few hotspot tests. So for example, this KRAS G12D mutation, you can have 2 independent cancers, both with the exact same mutation on that hotspot. So it's hard. It's really stressful. I actually saw a patient today about it. But it requires a lot of diligent surveillance and looking. You got to find where that's coming from if you can. And then sometimes it goes away, which is even more maddening.
Okay. And then I'll ask my question that I ask every year, I guess. I mean, Dr. Smith has heard this before, but this is a question that comes often up in rectal work is, those people who have a PCR, like pathological, or who don't have a PCR, and there is like tumor found at surgery. They're always concerned that what treatments they have had, is that enough? Or, would they need something more to prevent or to reduce their chances of a future recurrence or progression?
So my perspective is that if you have had adequate chemotherapy, you've had adequate chemotherapy. We have a lot of information about that, like fractional benefit of later lines of therapy. And again, you don't know the trajectory. You don't know if you're seeing dead bits or living bits. So if you have had the appropriate chemo, I don't think that more is going to do it. And I don't think that there's evidence that suggests that you should switch to chemo, that you take a metastatic regimen like FOLFIRI and start trying that in the postoperative setting, especially when we have adjuvant clinical trials going back now a decade. Some of them led here in Boston where FOLFIRI failed. So I think that just speaks to the wide variation of what you see in surgery. That doesn't mean that the cancer is growing. It just means you had cancer in the first place, and some people have more of a response and some people less.
Okay.
But yeah,
I think
in the chat. Of course it's significant.
Yeah, I think what we like to see there is that the tumor has responded, and I think I tried to bring that up, that you want to see that at least you've seen some response. You've downstaged it some from, maybe you had a T4N2 tumor and now it's a T2N0 tumor. That's a great response. You've seen a significant downstaging, and then that makes surgery easier on the patient and on the surgeon. So it just suggests that you've taken this big, bulky, nasty tumor and made it a little bit more tame. And I think that's helpful. Sometimes we're not fortunate enough for that to happen. Sometimes tumors don't respond, and I think then that's a difficult situation where then maybe there is a discussion about changing modalities of therapy. But sometimes those discussions can happen before you get to surgical resection. But those are few and far between.
But switching it to a regimen that's not known to change the outcome, I think, is probably not a good idea. Obviously,
correct.
The better chemo works, the better the outcome. The better radiation works, the better the outcome. But that doesn't mean that if the chemo fails, trying a different chemo is going to change the outcome. So unfortunately, the die is kind of cast biologically.
Okay. So what I'm hearing is that patients should not, be really caught up about the degree of response, but any degree of response, that any kind of downstaging indicates that their tumor is responding, and that is supposed, patients should look at it as good news rather than only thinking that if I only have a PCR, then my outcomes are better. Because in some cases, people with the PCR can also have recurrence, right?
Correct.
It's not 100%.
Yeah, it's stressful because there's no guarantees, and it's I've described it in a variety of things as spooky music, right? Like you have this big tumor that's left behind. You're like, oh, that's really bad. And you hear the the background music from some scary movie, but then it doesn't come back. And then sometimes it comes back when you don't expect it. And so obviously that informs how we think about risk, but I don't know that we can change that risk.
Yep.
And the lack of response, or if you don't see any sort of response, that might speak more to the biology of the tumor better. Yeah. Okay.
Correct.
Yeah, I think one person who joined late is asking, is pathological complete response significant? And I think this is the discussion that we just had. Right?
Yeah, we always celebrate when we see it, but it's okay if we don't see it.
But it's not a free lunch, right? No. Patients with clinical complete response still develop local regrowth. Patients with pathologic complete response still develop metastatic disease. So 6 to probably 10% of patients with a pathologic complete response, meaning no tumor seen in that rectum. It's not a single viable tumor cell in the rectum or in the lymph node basin. with negative margins. Some of those patients still develop metastatic disease. So it's not like you win the lottery and you're free
can't
forever.
escape surveillance.
So
you're committed,
right? You still have to be under surveillance. So yes, pathologic complete response is an amazing outcome, and the overall oncologic outcomes are better for those patients. However, we still have to have them under surveillance.
Okay, we have a question. What would be the surveillance program you would set for someone who has had a LAR to fix a rectovaginal fistula and a growth or regrowth of a polyp? Precancerous at the time of colonoscopy, not precancerous after LAR. I'm talking about a polyp that reappeared 8.5 months after the end of radiotherapy for a stage 0 rectal cancer, positive margins after transanal resection of what was thought to be a precancerous polyp. So what would be a good surveillance program for such a patient?
So the LAR was for a rectovaginal fistula initially?
Yes, to fix a rectovaginal fistula.
And then had a polyp.
Yes, a regrowth of a polyp. So it was precancerous at the time of colonoscopy.
And this regrowth of the polyp was in the rectal stump, I assume. Because you have an LAR and then you have distal rectum below that. Well, it was never really an invasive cancer, right? It was carcinoma in situ. Yeah. So this person is going to just have endoscopic surveillance and exams, right? There's no invasive cancer here.
Yeah, I would say this is a situation where the best we can probably offer is maybe vitamin D helps with preventing polyps, and maybe aspirin is worth considering. There is data that aspirin can change those outcomes, so I think baby aspirin may be the and really, really careful surveillance. I can't skip your colonoscopies, but probably baby aspirin would reduce the lifetime risk of colon cancer in that individual who seems to get polyps by a few percent.
Okay.
So to be concrete about it, the way that we typically would do it here is within 6 to 12 months post surgery, you would have a endoscopic exam with the surgeon, and then you would have your full colonoscopy a year from surgery with the GI physician. And then based on what's found at that time, if it's another high risk adenoma is found somewhere else in the colon, then they're going to scope you again in a year. Some of them would even do it in 6 months, depending on the nature of the polyp, or start to move you out to 3 years if there's no evidence of further polyp growth. But then your surgeon, yeah, sure, yeah. If you're making polyps that frequently, you need to start thinking about
attenuated FAP. But so seeing a GI oncology geneticist type of thing, very important to make sure there isn't something else going on. We have to look for polyps elsewhere.
Okay, that sounds good. Okay, we are at the end of the hour. So thank you very much for the fabulous talks. A recording of the video will be placed in Paltown University in about 2 weeks. Thanks to everyone who was able to attend, and thanks to both of you.
Okay, thanks so much.
Bye.